Hello, and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host today, Raj Gupta. I'm coming to you from Nashville, Tennessee. I'm a professor of anesthesiology at Vanderbilt University, and I have the distinct pleasure of talking to some experts in headache management today, and we're going to talk about advances in headache treatment. This is a big problem, particularly migraines, for a huge population in the United States and across the world. And we're going to talk about some of the latest updates in medications and therapeutic treatments for these patients and hopefully improve their quality of life. Before we get to that, I do want to make a couple of announcements related to ASRA pain medicine. First off is, if anybody listened to the podcast last month, we're starting a new trend. We're actually sponsoring each podcast with one of the special interest groups within the ASRA Pain Medicine Society. So this one, there's a special interest group for headache management, and so they're sponsoring this podcast, and we're talking about their topics. And each month, we're going to have a different special interest group that's going to be represented in these shows. So I think it'll spread out the topic areas that we're talking about and make for a broader audience of material to cover within this podcast. Second thing, the Green Anesthesia Special Interest Group is hosting a webinar on October 1st, Saturday, October 1st. And this is a webinar open to all members, and you can register, members and non-members, and you can register for that webinar. I'm going to put the link up here on the screen. And you can go to this link and register for that webinar. It's a full day talking about environmental sustainability in relationship to your acute pain, chronic pain practice, and what we as anesthesiologists, pain physicians can do to help be environmentally conscious in our medical environment. So I think it's going to be a great panel of speakers, a wonderful set of topics. I've seen the schedule. It's really remarkable. So I encourage you to go to the link and register for that webinar. Second thing is I want to mention that the ASRA Pain Medicine Fall Meeting, which is focused primarily on chronic pain management, is coming up very, very soon. But the deadline I really want you to know about is the abstract deadline. So this is coming up August 23rd, and I want to encourage you guys to go to that link and submit your abstracts for this meeting. These meetings are always phenomenally attended, great science, great clinical learning, workshops, hands-on experiences, and of course the connections and collaboration with experts across the country and across the world, in fact, in pain management. And I encourage you guys to go to the meeting, but also submit science. Of note, they are doing a special type of abstract during this meeting. It's a humanities-based abstract. So they want to see submissions from the membership on art, poetry, other visual arts like painting, music, anything that you can think of in the humanities. And this is part of an effort to think about wellness and well-roundedness as part of pain management, both from a professional side for the clinician, but also from a patient perspective in how they deal and cope with their pain struggles. So again, a really unique opportunity during this fall meeting. This is the first one that we're going to have. I've got in my pipeline a couple of photography abstracts I'm going to submit, so we'll see what kind of reception they get at the meeting. With those announcements, I do want to move on to our guests. Let me get everybody up on the screen and let you see them. So I want to introduce our guests. I'll go through each one one at a time. So first off, I have Meredith Barad. She's a clinical associate professor of anesthesiology, perioperative medicine and pain medicine, as well as neurology and neurological sciences at Stanford University. She's board certified in headache and pain and focuses on facial pain. And Dr. Barad is a co-director of the Stanford Orofacial Pain Program. That's a little difficult to say. That's a lot of words there. And serves as the program director for Stanford's Pain Fellowship. Dr. Barad is the ASRA Pain Medicine Headache SIG newsletter liaison, so already involved in these special interest groups. Second, I've got Gaurav Chauhan. Gaurav is an assistant professor of anesthesiology and perioperative medicine and director of the neuromodulation research at the University of Pittsburgh. He was a FAIR Scholar at the 2017 ASA annual meeting and the May 2022 ASRA Pain Medicine Member Spotlight physician. His current research focuses on determining the comparative effectiveness of interventions used for chronic pain management and is currently working on a curriculum development for ultrasound and chronic pain interventions. And then last, definitely not least, is Nat Schuster. Nat is a headache and pain neurologist and associate professor and clinic director at the UC San Diego Center for Pain Medicine. He's an ASRA Pain Medicine Headache SIG chair and executive vice president of the World Headache Society. So I'm hoping you know a couple of things about our topic today. He's a recipient of the Migraine Research Foundation 2018 Impact Award and section editor for the Neuropathic Pain section for the journal Pain Medicine. His research interests include headache and neuropathic pain and is currently conducting the first placebo-controlled trial of cannabis for acute migraines. So I want to welcome all of you. Thank you for being part of the panel and podcast today. I'm going to take a moment and I'll start with myself. We always like to start with any disclosures of conflicts of interest. So just as a disclosure, I'm a member of the board of directors for ASRA Pain Medicine. I'm also an associate editor for the journal Regional Anesthesia and Pain Medicine. I don't think any of those affect my conflicts during this topic of conversation. Meredith, anything to disclose there at the beginning?
I'm currently participating in a clinical trial for Rimigepant and trigeminal neuralgia. So I don't know if we're going to get into that, but if we do, I will acknowledge that. And I'm an associate editor for Pain Medicine, the Journal of AAPM.
Great. And Gaurav?
The only conflict of interest I have is that I have migraines at times.
Yeah, I have some every now and then too. So I should have disclosed that at the beginning. But I don't make much money from them.
Yeah, absolutely. So similar to you, no conflicts of interest for this podcast.
Great. And Nat? I think you're muted, Nat.
I've spoken for Eli Lilly on a couple of the new migraine medications, and I've done some consulting for Eli Lilly and for Lundbeck about some of the new migraine medications.
Fantastic. So let's just dive into the topic. So I'm going to kind of share an article that was passed around with us, and that's sort of our anchor of our conversation. It's not going to be the complete conversation, but there was in 2021, the American Headache Society consensus statement. It was an update on migraine treatments, integrating new migraine treatments into clinical practice, and this was an update to a previous consensus statement, and the entire focus was to give clinicians the latest research on what acute treatments and preventive therapies are available for patients dealing with migraines, either intermittently or chronically. So, Nat, I'm going to start with you. And from a high level, as you kind of think about headache management in the current state, in the past it was triptans and that's about it. Things have evolved quite a bit. Where do you see the current state of migraines? If we were talking to a more generic population of people, not headache specialists, how do you group the categories of opportunities there are for headache management right now?
Yeah, so what we've always been doing for patients is most often, if a patient's coming to, say, a chronic pain clinic like the ones that we practice in, or to a tertiary headache center, most of these patients are going to need two classes of treatments. They're going to need a acute or an abortive treatment. So you mentioned the triptans, for example, are in that class, and that's what people take when they get a migraine. But then most of these patients also need to be on preventive medicines or prophylactic medicines. And so for so many years, we used three classes of medicines: anti-epileptics, antidepressants, and antihypertensives as migraine preventive medicines. And then 2010, we got for the chronic migraine patients, so those who had more than 15 headache days and more than 8 migraine days per month, then now you have Botox, onabotulinum toxin A for chronic migraine. And so then we had no new treatments coming to market until 2018. And that's when we got this new wave of medications that we're here to chat about today, where we first got 3 monoclonal antibodies in 2018 for migraine prevention. And then in 2020, we got 2 new oral medications for acute treatment initially for migraine. Plus, we got another acute treatment that targets the 5-HT1F receptor. And then come 2021, we got another medication that was a small molecule CGRP antagonist for migraine prevention, plus one of these acute treatments, rimegepant, also got a indication for prevention, and as well as some of these non-invasive neuromodulation devices when more of them hit the market. And so this new wave of treatments, and the one that I think has gotten the most buzz is the CGRP class of medicines. And so CGRP is calcitonin gene-related peptide, and this is a sensory neuropeptide that since the late 80s, there's been research about its role in migraine pathogenesis. And so it took a while before we started getting drugs that are going to um, selectively bind to either CGRP ligand, which are monoclonal antibodies, or to the receptor. And so we both have one monoclonal antibody that binds to it, as well as 3 small molecule antagonists. And it's been really exciting to have this new disease-specific class of medicines to treat migraine.
And Meredith, so when you are looking, so you focus on trigeminal pain, facial pain, obviously headache fits into that as well. Is there just excitement about these new drugs? Are you starting to see them in treatment, or are there early trials? Where are these in their trajectory? Or are they so cost prohibitive that they're like 4th or 5th line for patients?
Well, for migraine, most insurances are still mandating a stepped approach to using these medications. By stepped approach, that means you have to have tried and failed some of the less expensive preventive options or less expensive acute options before you're allowed to access these newer medications. They are only approved thus far for migraine. So for things like trigeminal neuralgia, there's a lot of interest in it, but it's not FDA approved yet, and off-label use obviously is not paid for by insurance. Maybe Nat, you want to talk about the one thing about CGRP is that it is more dense and found much more heavily in the trigeminal ganglion, which is why it is so exciting for headache and facial pain. A lot of people have been excited about trying to use it in other ganglia throughout the body, but it doesn't seem, as far as I'm aware of, to be as robust in other sensory ganglia.
Right. So in non-headache pain conditions, we don't have evidence yet of these being effective. But where they seem to work is at the trigeminal ganglion. And so they're not going through the blood-brain barrier, and they don't have the CNS side effects that we've seen with so many of the migraine medicines that we've given patients in the past. And so that's a huge advancement for our patients. Just the tolerability of this class of medicines is much better, and largely probably because it doesn't cross through the blood-brain barrier. So you're able to actually treat a central nervous system disorder via the trigeminal ganglion without having a drug that crosses the blood-brain barrier.
Yeah, in the article they give a nice cute name to this category, the GPANTs, or am I saying that right? The GEPANTS, I guess that's the end of the name. And then there's another one called the DITANs, which is slightly different receptor. But one of the comments made in the article was that compliance is poor with preventive therapies for traditional medications. But some of these are, especially the murine antibody, the monoclonal antibodies, are once a month, once a quarter injections. And so you're getting something that hopefully has a long-acting effect. Gaurav, have you ever used any of these medications? Are they not quite in your practice yet in chronic pain? Or I think you're muted here.
Like they say, it's very difficult to get insurance approval for these medications. And then usually like Dr. Barad said, it has to be a stepwise approach. Documentation plays a huge part into writing down that, hey, patient has tried other medications and has failed 2 triptans in combination of triptans, and patient has also failed other conservative medical therapy, Botox injections. And in consultation with neurologist, I think using a GE PANT could be a viable alternative for this patient. Like there's a lot of insurance regulations with these medications, and then patient compliance also remains poor. But I have been, I try to in consultation with neurologists, prescribe Rimagepant to the patients. That's sort of my go-to drug because it is both acute and preventative medication as well. And like they said, the side effect profile is a little bit favorable. It does not have a lot of side effects like tricyclic antidepressants or triptans have.
And one of the things that I saw in the article was that it seemed to be that the American Headache Society, in collaboration with some patient advocates, was really trying to make a statement that our current recommendations or requirements from insurers is too stringent for adequate patient care, often too delayed for adequate, considering the amount of quality of life impact that migraines can have on patients. There was one quote that said that the migraines are associated with a almost an annual cost of about $27 billion in the United States alone, mostly in lost productivity. And I know, as I mentioned earlier, I have luckily not chronic migraines, but I've had the occasional migraine and ended up in the emergency department. It was so bad because they can be quite debilitating, and I've seen several friends who are can't work because of migraines. So I think some of the things said that these trial periods can last 6 to 12 months. Is that what you guys are seeing? Meredith, are you guys seeing people having to go through long periods of these traditional therapies before they can get to these current therapies?
Absolutely. I mean, this is a really big issue. And the American Headache Society scientific meeting, there were many people that were discussing the almost injustice of this issue. And one of the abstracts that one of my groups published was we went back and we looked at all of the literature that has been used to build consensus and to determine what are the best medicines. So, for example, you might have read in your medical school book that propranolol is indicated for migraine treatment. But when you go back and you look at those studies for propranolol, there were 10 patients in 1960 in a maybe a single blinded trial, maybe single blinded at best. And those really bad studies were used to lead to the American Headache Society and the American Academy of Neurology saying that they are probably effective. And that's sort of become our gold standard. Compare those 10 patients in 1960 to the very large, extremely well done randomized controlled trials, double-blind randomized controlled trials of the MABs and the GPANTs today, and there's really just no comparison about how the science was done. So we are struggling as a group to reframe the conversation and to advocate for our patients, because I think most of us feel that these are superior treatments. They have better science behind them. In our clinical practice, patients adhere to them, patients find them more effective, and patients don't come back, which is, a lovely thing for a migraine provider when a patient says, I don't need to see you anymore, Dr. Barad. My headaches are good and well controlled.
One of the things that you mentioned, Nat, at the beginning was that there was an evolution from, a opportunity for these new medications, but then there's also opportunities for neuromodulation. I'm going to go to Gaurav about this after you, Nat. Tell me what's happening in neuromodulation, because what I'd seen a few years ago was implantable stimulators. People putting in things very close to spinal cord stimulators, but with multi-lead endpoints that were inserted under the skin, either for supraorbital nerve headaches, for the frontal headaches, or occipital nerve or auricular nerve placements. And these are not benign treatments. They were traumatic, and people I saw many times had erosion of leads go through. It sounds like people have moved on from that. Is that correct? And what's the current neuromodulation therapies that people are using?
Yeah, so three big established neuromodulation companies. They did trials looking at occipital nerve stimulation in the early 2000s, and none of those were really had a good enough signal for efficacy. Also taking into account the complication rates, that those three companies wanted to further explore that. So at this point, insurance coverage of occipital nerve stimulation is pretty limited. And certainly, I think everybody, whenever I've probably the last, 4 conferences I've been at where there's been panel discussions about this topic, that the consensus has been that certainly patients should be using onabotulinum toxin A and the CGRPs, trials of monoclonal antibodies before you're thinking about implantable therapies. I'm sure there's going to be ongoing clinical trials using some of the newer peripheral nerve stimulators and trying to develop and further explore peripheral nerve stimulation for migraine. But at this point, it's certainly, not where it was. The enthusiasm's not where it was before we got the CGRPs and onabotulinum toxin A. But we have these non-invasive neuromodulation devices. And when it comes to at a societal level for the 38 million Americans who have migraine, these non-invasive neuromodulation devices don't have nearly, the dent big picture on migraine that the medications do, because they're not being used nearly as widely and they're not being covered by insurances. So in my practice, I can get CGRP monoclonal antibodies or GPANTs covered for my patients. I know what steps to take them through. I can get them very quickly. But the non-invasive neuromodulation devices, of which we have at this point 5 of them, by and large are not covered by insurance. So the first one that we had was a supraorbital nerve stimulator called Cephaly that patients wear on their forehead. And that is, at this point, it is over the counter. I can just give patients the website. They can go online. They can order it. It's not cheap. And it's helpful for some patients, not helpful for everybody, but certainly something that I've recommended for many of my patients.
What is not cheap, out of curiosity? Do you know, is it like hundreds of dollars, thousands, tens of thousands?
Around $400.
Okay. All right.
Yeah.
Well, I mean, if you're in pain, a visit to the ER costs more than that. So, $400, if it works for you, may not be expensive. Depends on how you're looking at it.
Yeah, absolutely. And patients, if they find that it's not effective, they have 2 or 3 months that they can mail it back and get their money back. So that was the first one. And then there is a single pulse transcranial magnetic stimulation device, STMS Mini, and that has the best evidence for migraine with aura. So then that one came to market, and then another one that's a vagus nerve stimulator that patients hold up to their necks, and they can use that for some of the trigeminal autonomic cephalalgias, including cluster headache, as well as for migraine. So that was the third one that came to market, and then the fourth one is a device called Nerivio. That's an armband, and so they discussed that in these new guidelines. And that one can only be used at this point for acute migraine treatment. And that works by what they call condition pain modulation, where it is somewhat noxious and it triggers descending inhibition as a acute treatment for migraine. And then the most recent one that I think is still in a limited launch, but I probably have maybe around probably 10 patients who have used it at this point, is a combined supraorbital and occipital nerve stimulator. And that's called Relivion. And so that's the newest one that's come to the market. And so all these can be used for some patients. I use this almost invariably in patients who have already tried some of the things that are covered by insurance, with the exception being those patients who say, "Doc, I do not want a medication," then I might go to some of those. But for the most part, I like to have my patients using the things covered by insurance before we start going into some of these things that are not covered by insurance.
So Gaurav, Nat talked about several of these, and I know you have an interest in neuromodulation. Have you had an opportunity to use these on your patients? What has their experience been like with some of these things, if you have?
So Neuralink for Relivion, this occipital and supraorbital device is something that I was looking into, and there is no there is the studies done on this device are basically done by the company. There is no institutional or third party studies at this point that I'm aware of. Um, I haven't used neuromodulation for this, but we have used intrathecal pump therapies using pre-alt and opioids for migraine headaches. Um, Making sure that the catheter is really high at like C2, C3 level. And we actually published on one of the case reports in which we used lumbar pre-alt therapy and patient has resolution of migraine. Neuromodulation, like Dr. Shuster said, it's a lot of issues when we use neuromodulation for migraine treatments. Basically, number one limitation is that you can cause infections, you can make things worse. Lead erosions, lead migrations, and accessing the cavity can sometimes be a problem. Like there was phenopalatine neurostimulation um, that was trialed in Europe in 2014. It didn't catch on because it really sits in that foramen and can induce infections. Foreign body in that place can definitely induce infections. So neuromodulation did not actually catch up for migraines, uh, unless it's non-invasive, and then non-invasive does not have like a large data a body of data behind it. But I think
So,
G pens and these newer treatments are more effective than some of the data published by non-invasive neuromodulation and can prove
so
to be more.
I'm going to play my ignorance card here. So you said something about the intrathecal,
Yes.
high intrathecal placement, and you said pre-alts. What does that mean? What does pre-alts mean?
So pre-alt is ziconotide. It's one of the medications that we use for chronic pain, for refractory chronic pain. We use pre-alt treatment therapies in intrathecal pump. Um, like I
So that's
said,
not stimulation. That's you're not putting
that,
stimulating
that,
wires intrathecally.
that's not stimulation.
Okay,
That is just intrathecal therapies that we used, and like
I see.
the evidence is anecdotal. Like we had few case reports in which it worked for migraine patients.
Okay, so still pretty experimental or
Yes.
novel treatments. Yeah, Meredith.
Raj, can I? Yeah, I just want to interject here. So, um, Nat and myself and a consensus panel um, put out a nice paper reviewing all of the procedural studies available, randomized controlled trials for migraine, and it was part of our consensus panel that there were no randomized control trials looking at intrathecal medication for migraine. And so we recommended strongly against it. So I do think that that's like very, very strongly anecdotal.
Yes.
I do think maybe we could go back to stimulation, to implantable stimulation, because I do think this is going to come around on the guitar again with all of the peripheral nerve stimulators that, Sprint First, which has gained approval by the FDA to implant above the neck. And so the biggest issue with implantable stimulation when it started back in the early 2000s, and we had several large randomized controlled trials looking at various different types of ways to implant stimulation, is that it moved. And that is the problem with the neck, is that it is a very mobile place, and it's a struggle to really get the stimulators to sit and to stay put, and for that to translate into effective pain control. So you had something like 40% side effects in the patients, and 20% movement of the stimulators, and like these are big numbers, and that's not gonna work well for carrying this into the future. But if you could solve that issue, if you could do maybe a temporary peripheral nerve stimulator for somebody that's having an acute exacerbation and really getting into a hot area of their headaches, there's a lot of, I think that there's a lot of interest in peripheral nerve stimulation, and I would say like there's a lot more science in there that we should go to and look to and get excited about, rather than intrathecal, which I think really puts our, is kind of needs a lot more science behind it before we're ready to say that's the next option for patients with migraine.
Yeah, there are newer generation neuromodulation devices like StemWave that do not require an IPG. Like the IPG is inbuilt inside the lead itself. So all you need to do is just implant it, and there is no IPG outside. Um, and all you need to
IPG's implantable pulse
yes,
generator, right?
yes, there is
Yeah.
no, unlike Sprint, in which you have to connect to an IPG and take out the device after 60 days. StemWave can stay inside in the occipital region, and it's IPG free. So all you need to wear is a special collar around the neck to activate the device and give you neuromodulation or stimulation.
Yeah,
So
and I want to just second, what Meredith, said, both, from when it comes to um, intrathecal therapy not really having the evidence, but also, talking about the role of opioids. And certainly, opioids we know can cause medication overuse headaches. So it's always been a struggle to try to keep people, like in chronic pain treatment, away from opioids, getting them off of opioids. And so for example, one of the consult questions I used to get from neurologists before this new wave of medications came to market was a patient who was on a triptan, they had an MI, they were really good triptan responders, and now what can you do for them? Should this patient be getting opioids because, well, they're not a candidate for triptans, and due to their comorbidities, they're also not a candidate for NSAIDs anymore. So before 2020, well, the answer used to be, I guess we can try some D2 antagonists, things like metoclopramide or prochlorperazine, for example. And now we have with this new wave of medications, we have the GPANs and we have this one Ditan that do not have the cardiac contraindications that come with triptans. And so, if the question is, should this patient be on opioids? The answer is no, of course not. Here we have 3 new medications. Let's try some of these. And these non-invasive neuromodulation devices also are really good options for those patients.
I do want to bring back one of the comments that the article talks about at the beginning, which I think that we should, in our due diligence, emphasize, is that patient education, lifestyle modifications are still the mainstay of primary therapy. Nutrition, exercise, stress, sleep, hydration, and then one thing I found very interesting and makes so obvious sense, but because I haven't been in this conversation before, is the migraine diary. Much of what you talked about the different therapeutics depends a lot on what type of migraines, how often the migraines, how debilitating they are. It seems like that migraine diary is the beginning of all of those conversations. As we wind down this conversation, I want to give everybody a chance, if there's any last thoughts you guys want to make. Sort of my summary kind of assessment from an outsider's point of view on this is that we're not stuck in 2000 anymore. We're not stuck with and limited to some of the therapies. There has been progress made. There are opportunities for patients. There's still some hurdles that are going to be challenges for patients and clinicians, but there's optimism there as well. So it's still an exciting field to look at. Meredith, any last thoughts before we wind this up? And again, if you want to tailor it towards your focus on trigeminal neuralgia pain and where some of these therapeutics kind of lead into that, I'm happy to let you mention that too.
I don't have any exciting science to share yet, so we'll have to have another webinar about how they are on facial pain. But I do think it's an exciting time, and I think that ASRA has really invested in educating its participants about these new treatments, and I think that's great for providers and I think that's one of the reasons why ASRA is such a great place, is that you can come and learn about all the new developments in pain. So thank you, Raj, for having us on.
Yeah, absolutely. Nat, any last thoughts before we wind up here?
Yeah. So first of all, again, thank you, Raj, for having us. And so one thing that I'd like that I like pain doctors to take from this is thinking about, this with these new medicines, we have disease-specific treatments that are well tolerated and are effective, and hopefully can give hope to pain doctors thinking about, hopefully these are the sorts of medicines that we want to have in the chronic pain field as well for our patients. So I hope that this should give us hope, and I think that there are a lot of lessons to take from these new medicines. Also, I want to give a plug to the ASRA headache and facial pain SIG is having a headache and facial pain case discussion on July 27th. this year in the evening. So if you log on to the ASRA website and you go to the headaches SIG
I've got the link right
page.
here on the
Oh,
screen,
wonderful. People can sign up.
azra.com/sig/headache. So that'll jump you right to the headache SIG, and I think the banner for that. And I apologize, I didn't put that in the announcements at the beginning. So July 27th, is that the correct date? July 27th. Yeah, that's great. That's awesome. That, one of the things that, and this is a plug for what ASRA Pain Medicine as a Society is doing, is we're really empowering the special interest groups, these SIGs, to generate content and find experts in the field. One of the complaints the society got for many years is that there's only a couple of people talking on the podium, but really the topics are diverse and have little niches within them. And so these special interest groups give us a podium, a platform for these conversations for people interested in these smaller niche topics that then get brought to the main stage over time as they mature and get the attention of a larger group of people. So azra.com/SIGs for any of the SIGs to look at, and then /headache if you're interested in this topic to see what else is coming up. You beat me to the punchline on the link. I was going to do that anyway, but that was good timing on that.
Wonderful.
And then Gaurav, any last thoughts? Now, and Nat, going back to you before I get to Gaurav, is I intentionally left out the cannabis discussion because that's like a whole 2-hour conversation. So it's not that I ignored that part of treatment. It's let's see where that's going in the research, and maybe the next time around we have this, we'll have more data on cannabis for migraine treatment, or maybe we'll have a longer cannabis discussion, broadly speaking, because there's a lot to discuss about that topic, and it doesn't seems to have something new every 6 months. So hard to keep up with that topic.
Yeah,
Gaurav, any last?
absolutely.
Yeah, we'll get you back on this. Gaurav, any last thoughts before we wrap up?
Yeah, I would like to echo the sentiments of Dr. Barad and Dr. Schuster. Precise patient education, physician education is also very important to bring these medications mainstream, so that physician can tell the patient, hey, these are options available to you. Go talk to your insurance. Why are they not being covered? So I think these podcasts go a long way in educating physicians like me. And I think ASRA has done a wonderful job. Till these medications come in textbooks that we read, I think it's still early, and I didn't see any textbooks, discussing these medications. And there is lack of education when it comes to chronic pain physicians regarding these medications. So they are like reluctant in prescribing them and discussing them with their patients. So I think physician education goes a long way, and ASRA has done an amazing job with this podcast, and I hope they continue this.
Absolutely. Thank you. And I'm a firm believer that, all of our decision making should be rooted in science as much as possible, but the science moves at a certain pace, textbooks move at a slower pace,
Absolutely.
and then innovation, research, clinical experience moves at a faster pace. And somewhere in the middle of all of that, we have to get to changing practice over time, hopefully as much evidence-based as possible. So I'm a firm believer in sharing information on these platforms so that we can learn from each other in that fastest phase, but then hopefully the literature follows to give us more sound grounding on some of these therapies as people are exploring options for their patients who honestly are suffering on a regular basis. Some of them are and are looking for options. If those of you who are out there listening, and I encourage you to listen and then share it with your colleagues. These videos will be available afterwards on YouTube, Twitter, Facebook. You can share them all. We'll have the audio out on the podcast stream as well for ASRA RAP, ASRA-RAPP, if you want to subscribe to that podcast. But go to the Headache SIG's website, join the SIG, be part of the organization. They send out a newsletter periodically. They have these events. It's a great way to learn from colleagues that are doing this research, doing the clinical front-end experimentation and exploration. But also it's a great way to share your experiences back to the group so other people learn from your own experiences. So I encourage you to be part of the conversation and not just an observer. So those of you out there listening, and feel free to share and encourage your colleagues to continue this conversation. I want to thank you all, Meredith, Nat, Gaurav. It's a wonderful conversation about a topic that I don't get to do clinically, so I learn a lot from this experience. And my treatment of choice has been Phenergan, promethazine for my headaches. So hopefully there's a few more options out there if I ever have to. Luckily, haven't had a migraine in a while, but hopefully I'll have some options if I have to suffer through that one more time. So thank you guys for being part of this, and I look forward to seeing you at the meeting. Hopefully you'll be at the fall meeting, and I'll be there, and we'll get to chat in person as well. Thank you guys.